Thanks. Welcome, everyone. Thanks for showing up. And yeah, until the slides are up, and hopefully they will work. Okay, all right. Okay, let's start by talking. Now, thanks to the previous speakers, I kind of know about the composition of the room. So there's some population health people, clinicians, engineers. Is there anyone from the health funding side, insurance or regulatory government, doing DRGs and quality metrics, that sort of stuff? Perfect. Okay, this is going to be more of a didactic session, but I would like it to be interactive, so please do stop me if you have any questions. I'm keeping my own time, but yeah, we'll see how it goes. Maybe quickly about myself. So I'm a doctor by trade. I crossed to the dark side long time ago, like some of you, most likely. I was a full stack developer, and I earned my life for 15 years by creating my own software and selling it in Turkey, where I'm originally from. And then I decided to do a PhD in health informatics, and I moved to New Zealand. So I've been living in New Zealand for 17, 18 years now. Neck deep into standards, both FHIR and openEHR. So I got introduced to openEHR in literally an elevator in 2001 with Tom Beal. So I think it was 5 or 6 floors. So by the time we got into the ground floor, I was sold to it. So it changed my life. And of course, I had to do HL7 because I was kind of integrating my own systems. So I am one of the founding members of HL7 Turkey, and since I went to New Zealand, I'm on the board of HL7 New Zealand since 2012, and I served as a vice chair for 1 term. So I'm kind of belong to the both worlds, but in my opinion, the world is single. We just attach labels and different approaches, etc. Anyway, I think now I have the control. And the reason that I'm talking to you about value-based healthcare for an openEHR audience is because I had to kind of earn my life in New Zealand. There's not much opportunity to make money from openEHR, so I started a company. We built a PROMS on-premise platform, and we implemented quite large national and state-level implementation, mostly in the Australia, New Zealand, and Southeast Asia. And I learned a lot, and I also saw how we can actually improve and support it by appropriate use of the right healthcare data standards. So in this talk, I'm going to talk mostly about value-based healthcare and also look at the secondary use, again within the context of value-based healthcare, but it is applicable to other domains, including research. So value-based healthcare, how many of you haven't heard about it? Don't be shy. Great. How many of you have heard about it? Okay, so it's not it's a disjoint group. Sure. So value-based healthcare is really doing the right thing. It's nothing more. And if you unpack it, it's doing things in a way that it works for the patient, and it also works at the population level. And the core, I think, the critical point for value-based healthcare is to be able to calculate the quality of care, because this is one area that we are unable to measure. We have some clinical quality measures, safety measures, process measures, but health systems until to date, and actually most of them, cannot really measure the outcomes of the care that they are giving, especially on a longitudinal term for patients and for populations. Now we have these clinical quality measures. Appropriateness of care is really doing the right thing. It's clinical guidelines and protocols, how to comply with it. But the most critical part, and that's missing, is the patient-reported outcomes and the experience. And obviously, if you put the cost within that context. So the equation is just a conceptual kind of representation. The value-based healthcare is much more complex than this, but the critical thing is we need to be able to measure the outcomes of the care that we are delivering and then put it into the cost context. This is a crowded slide. I'm not going to talk too much, but just to say that PROMs are questionnaires that are filled by patients, but they are clinical assessments. So they are as important and as relevant as any clinical assessment that is done by the clinicians or allied health personnel and etc. Because they are filled out by patients, it's generally considered less reliable or a little bit loose. And from many health systems' point of view, the definition of a medical legal health record is any data that is generated by a clinician or any data that is interpreted by the physician and it's written into the EMR. Now, because this is all filled out by patients, it doesn't fall into that category. So for some countries, they don't consider PROMS data as part of the EMR. I mean, we can discuss about it, but it is so critical in value-based healthcare. Anyway, I'm going to move faster. They are validated using some scientific methodology, psychometric validation, to make sure that we are measuring the right thing in the right way. I put this slide as a reference. I think the presentations will be shared later on. Just to say that generally it's accepted that the PROMS data is used in 3 different ways. At the micro level, this is where the primary use is. So we administer PROMS for the doctors to deliver individual patient care so that, for example, if the patient arrives to a specialist appointment by filling out, for example, the pain about the hip or the joint or cardiovascular parameters, then the doctor has a chance to hone into the problems that matter the most to the patients, and it also facilitates shared clinical decision-making at the clinical call phase. Then the meso and the macro level is really more around quality assessment, quality safety, performance benchmarking. The healthcare providers do this quite often internally, but the use of PROMS hasn't been routine in most health systems. And at the micro level, this is where the population health research, health policy making, the kind of policy that, for example, Jordi is making for Catalonia is evidence-based, and they are collecting PROM data together with other data. What is really important here is, and this is led mainly by the US, is this data and these measures are now used for implementing new payment models for hospitals. Right now, around the world, most hospitals are funded by the services that they provide, so they do diagnostics, therapeutics, rehabilitation, whatever, and then they send the bill, and they get paid by a private or a government insurance. But this type of payment actually incentivizes hospitals that provide better care at lower cost or equal cost, and penalizes those providers that doesn't do that. So these bundled payment models, I think about 40% of the US payments are done using similar ways. And the Middle East is emerging as another center of excellence in using these new quality or performance-based funding models. This is an organization, a wonderful organization. Has anyone heard about EHRCON? Perfect. So I believe this community and openEHR shares a lot of common interests and goals and types of expertise, especially from the point of clinical modeling and creation of these standard sets. They have 46 standard sets which cover certain conditions. Each a condition, they define the data that needs to be collected, the schedule that data needs to be collected, and implementation guidance as well. So it's really impressive that the 46 sets that they kind of create, it covers 60% of global disease burden, so it's quite significant. And obviously, they have different working groups for different standards, standard sets from over 1,200 professionals, clinicians, population health specialists, health informaticians, health economists, etc. This is just to say that in addition to the data set definition, they also define the schedule at which with which it needs to be collected, and these are dynamic. So depending on whether this is for breast cancer, if you are a simple surgery, you are at the top. If you have chemo plus surgery, you are in the middle. If you are on the second one and there's recurrence, you jump into the third one, and the kind of data and the time that it needs to be collected changes. And because of that, health systems and providers now benchmark their data with other centers globally, participating sites. Every standard set has this wonderful wheel view of the domains of data that they collect and measure. And so the great thing is we usually use radar charts or radar plots, and we look at the individual domains and we put the reciprocal of cost. So closer to the rim means good stuff. And you can benchmark patient against population, patient versus patient, different treatments, among themselves. So it's a really, really helpful way of seeing the value very quickly. Well, it goes only so far, and unfortunately the data dictionaries that they publish on the website are Excel spreadsheets, and I tried to highlight this disappointment by putting a disappointed labubu, yeah, which is, is there anyone who didn't hear about labubus? Really? It's a shame, yeah. What kind of people are you? Yeah. Well, the thing is, they put all the clinical, administrative, treatment, prompt data into a single data dictionary. And if you take all the 46 standard sets, even just the clinical part is over 1,000 clinical data points, and they are complex. So, I think 3-4 years ago, at my company, with a student research group, we did a study to take the breast cancer data set and represent using FHIR. We did a very preliminary work. There was a separate group within the FHIR community that was already working on this, so we kind of joined them. And so that broader work ended up creating a lot of profiles just for the clinical part for the breast cancer. So things like treatment variables, a lot of tumor factors specific to breast cancer, treatment plans, TNM staging, etc. It's all modeled using a lot of profiles, which have a lot of extensions and different value sets. This was a huge amount of work, and we could have done this much easier using openEHR, and we will, with all this data collected, I'm always asking what do we do with the data before actually going and collecting. So this is a really cool thing that emerged from the US. So it's FHIR-based, but we made it work for openEHR as well. So the concept is to be able to detect gaps in care or care gaps at an individual patient level or at the population level. And what does care gaps mean? So for example, if a woman with breast cancer risk comes to a GP or a hospital, they are usually put into a screening kind of follow-up program. And if that follow-up doesn't happen, that screening or in any other conditions based on the clinical guidelines, it's basically a query language and a logic mechanism that is defined in FHIR clinical quality language, and most decent FHIR servers or CDRs already supported. So what happens is everything happens on the fly, like in autopilot. If you have patients which which should have had some intervention or data collection and they didn't, then they alert you so that you don't get penalized by CMS or other private payers. So, what's happening on the openEHR front? We have a PROM working group under clinical program board, and we have been working for, I think, more than a year now. We did some good progress in defining a modeling guide for PROMS assessments, but there's still some work left, which we want to finish. We want to publish, and we have already published some PROM questionnaires or assessments on CKM, just alerting to the fact that the licensing and IP and the fees may be quite prohibitive for some implementation. And in the future, maybe it's my personal wish, but we also would like to, model all the care pathways and etc. using openEHR so that it's published and any vendor or any hospital, like expert clinician, can implement as they want. We also have some ongoing conversations for a more formal engagement or collaboration between ICHOM and openEHR. And again, as I mentioned, these communities have a lot of common interests and resources and culture, I guess. ICHOM has started building some learning collaboratives. For breast cancer, there's one large with US-based and Ivy League hospitals and some key hospitals like Charité and Karolinska. So they are basically sharing all their learnings based on the data set that they collect. But I think it has parallels to the openEHR network in Europe, which is Severin here still? Oh, he left. I'll ask him to buy me free beer. Anyway, like this is all about making use of data in a meaningful way so that you can get the best out of the data that you collect. So these kind of, once the data and the governance and processes are agreed, the use of linked aggregated data, multi-site data is really, really valuable for all sorts of use, from primary to secondary and etc. Anyway, why bother? Yeah, because most of you don't know that there's this whole cosmos of things happening, and there's a lot of money going into this domain. So I think it's a big opportunity for us as a community to kind of delve into this and explore and solve some real-world problems, whether you're a clinician or you're a health informatician, a vendor, a consultant, etc., etc. So there are very good opportunities in this space. Yeah, that's I want to highlight it. How am I doing with time? 1 minute?
2 more minutes.
2 minutes, okay. We do have some archetypes already on the CKM. And we have a wonderful openEHR-based PROMS and PREMS platform from the Aperta Foundation. The people who built it is actually part of the conference, Steve Wilkinson. Yeah, you can, oh, he's actually there, you see? Nice, tall, good-looking gentleman, yeah. Yeah, so the secondary use part, I kind of wanted to do it more from a value-based healthcare point. So the FHIR CQL looks like this. It's a very readable kind of language, I guess, that you measure your like the patient population. Then you define the cohort that you would like to measure, and then you get those patients either individually or on a population level, and you do something with it. You can do some reporting, etc. So this is a much nicer view of this logic and query, which is done for AQL, for the data that's in openEHR format, and yeah, it just works and it's brilliant. So this is like a first sneak preview of some of the work that we are doing with Christian Chevalier. So he's the original creator of EHRCON25, which later became as airbase. I hope I'm not kind of doing any politically incorrect statements here, but he basically created a federated system, some components that you can actually use to query, and you can create an EHR basically in that way using that distributed querying mechanism, which is agnostic. It could be FHIR, it could be openEHR, it could be OMOP, and a lot of those ugly proprietary formats as well. So, so the iteration 3 query equivalent is we have the clinical data in openEHR, CDR, and the FHIR has the lab tests. So we are kind of defining the patient cohort, the denominator from openEHR, by looking at diabetes patients, and then we are filtering those HbA1c tests from the target population, and the result is a query, either one patient or a cohort of patients, depending on the use. And this domain-specific language is not only able to query, but you have data definition language and data manipulation language, DDL, DML, which means you can actually create compositions or FHIR resources, in using this language. And yeah, you can use different programming languages. And Python, it's written in Kotlin natively, and it also has amazing things like HTML formatted queries. So we are querying an IPS and getting this nice HTML out of the query, which you can just use in different ways. So thanks for coming in, and sorry that we didn't have time for questions, but. Do we have a couple of questions?
Sorry, we've got time for a couple of questions.
Okay, that's great.
I've got a question.
Cool.
It might be like a philosophical question, but can you truly have value-based healthcare in an industry that profits from people being sick?
Well, we have to, because there's no other way. The healthcare system is very constrained, financially, resource-wise, and this is just really the value-based care is not done in isolation. It's actually almost like an end result of doing the right thing for the right patient, and at the right time. And if you do those things, then you actually can measure the outcomes and reward the carers that provide better care and penalize others, so that it kind of creates an incentive to do higher quality work with better outcomes. Right now, the incentive is to put as many services, procedures, tests into an invoice and then give it. So in a way, hospitals are actually incentivized to keep patients sick and do a lot of overcare and waste, unfortunately.
Any other questions?
Yes.
I'll just shout. Sorry.
Yeah.
How do you ensure you don't get any bias in value-based healthcare where the costs outweigh, but perhaps the moral imperative is more determinant?
Public or private or both? Okay. Most people who talk about value-based care says it's better outcomes at lower cost. My experience has been most of the public providers, they actually don't, like their first objective is not to lower the cost, because obviously the cost is gone, but it's gone from one center to another. So they use these extra funds, and if they cut the waste, they go, implement better screening clinics, hire more people, train them, etc. I know that I didn't answer your question, but it's hard, and I think the best way to get around it is to build a really strong community and kind of have a sense of ethics and process and all of those things. And I think the IHM community is really doing just that, and it's a really, really good to be part of them.